O dabar jau tikrai nuo žodžių prie darbų ir veiksmų pereikime ir aš nekantraudama norėčiau pristatyti pirmąjį pranešėją. Tai daktaras Alfgeir Logi Kristjansson, Vakarų Virdžinijos universiteto Visuomenės sveikatos profesorius, Prevencijos tyrimų centro pagrindinis tyrėjas ir direktoriaus pavaduotojas. Ir jis pristatys Islandiškojo prevencijos modelio pagrindus. Kadangi ponas Kristjanssonas pas mus negalėjo atvykti gyvai, taip pat šiuolaikinių technologijų dėka galėsime pasiklausyti jo pranešimo. Kviečiu naudotis ausinėmis, jeigu nemokate anglų kalbos arba galvojate, kad reikėtų pastiprinimo iš šono. Vertėjai tam tikrai yra. Palieku jūsų profesoriumi.
Well, good day, conference guests, and thank you so much for being here for all of us, and thank you to the organizers for having me here. My name is Alfgeir Kristjansson. I'm a professor of public health at West Virginia University in the United States, and a director of the Prevention Research Center here. I am from Iceland and have worked with the Icelandic prevention model more or less all my career, so you may have seen or heard a couple of things from me about the model or seen publications. I want to thank the organizers for having me here, and I apologize for not being able to be there in person since I am recording this ahead of time. Going to set my timer here so that I can stay on time. My presentation is titled The Foundations of the Icelandic Prevention Model, and I'm going to take you through the sort of core, both background ideas and evidence to date and implementation systems around the model. So just to frame the discussion, let's talk first about the size of the problem. There should be no ifs and buts to people that, substance use in all forms is a gigantic challenge in the world of public health and health promotion and community health. WHO has estimated that over 400 million people worldwide suffer from alcohol use disorder as one example. And alcohol use is, in fact, the one drug that kills more people than any other drug on the planet. The United Nations have estimated that over 292 million people used illegal drugs in the last 12 months, which is between 5 and 6% of the entire world's population. And SAMHSA, the Substance Abuse and Mental Health Services Administration in the US, has estimated that in 2024, I believe 48.5 million people suffered from substance abuse disorder or substance use disorder. These numbers are just to kind of frame for all of us how enormous this issue is. Of course, we know that there's plenty of people, adults, that use mood-altering substances like alcohol recreationally, but there are also many people that harm themselves and use harmfully and have the potential of really getting into trouble with their health and other issues. Now, prevention generally is divided between primary, secondary, and tertiary prevention. Primary prevention is the prevention of the onset. It's the idea that we can actually work upstream. We can prevent the challenges and problems that come along with drug use ahead of time. We know what issues are most likely to lead young people and kids to trouble with their use. And as a result, we can do a number of things to prevent those from happening. Now, of course, primary prevention requires us to think differently than we would with, for example, tertiary prevention, which is really the treatment system, working with people that already are suffering from substance use disorders or challenges of that nature. In primary prevention, we have to work upstream. We need to understand what the risk and protective factors are for use, and we need to understand the implications for kids beginning to use drugs very early. Secondary prevention is usually what we refer to as behavior change models or behavior change programs. Smoking cessation programs, for example, are very typical for that. That's when we're trying to have people change their behavior that already have started to use. Those are much more geared towards individuals, and they can be quite effective, but have a much more limited reach. Primary prevention has a much wider reach to the population. And tertiary prevention, as I said before, is essentially working with people that already are having lots of problems with their use. So the hospital system is a primary prevention system, for example, and therefore, obviously, the treatment system. Now, in the current scenario, and this is the truth for most of the world, we spend over 90% of all our effort, money, manpower, time, and so on, and other resources on the tertiary care. In other words, most societies, most governments, and most systems focus primarily on working on the tertiary side of prevention, that is, dealing with problems after they have become very serious. So over 90%, far and away most of our resources are spent on trying to treat people after they have become addicted to or suffer from really serious problems with drugs. Now, as you know, for every user that comes to drug treatment, there's usually a long pathway of challenges, of costly challenges, of time out of work, worried parents, worried spouses and friends that may have lost time from work and other things, costly implications for the judicial and law enforcement system, social services, and so on. So each individual that comes to drug treatment has already cost society a lot of resources. That is aside from the direct health effect on themselves and of others, which of course are very serious or can be very serious. And in addition, we should obviously remember that tertiary care or drug treatment is very ineffective as an approach to population recovery. If we are thinking about the entire population and we're thinking about preventing the problems associated with drug use, tertiary care basically has between 5 and 10% success rate at best. So it's already very costly. It's already costly also with regards to the actual treatment implications, but success rates are very low. Now, primary prevention, which the Icelandic prevention model is, and I want to advocate for, is different in the sense that it has a population focus. We're focusing on the entire population of young people. We know that early initiation of drug use, that includes tobacco, alcohol, and all the illicit stuff. We're not just focusing on illegal drugs. Early substance use is most likely to escalate into serious problems. We know this full well from lots of different research from different countries and places, that kids that begin to use drugs early, let's say 12 or 13, they are much more likely to get into very serious problems with their use a few years later. Therefore, they're much more likely to drop out of school. They're much more likely to engage in teen parenting. They're much more likely to be expensive for the healthcare and judicial and law enforcement and systems and so on. So in other words, there's really, really a strong value and argument for preventing the onset of drug use. We've also found from lots of different studies that there is a very high return on investment from engaging in effective primary prevention systems and programs. And usually those are calculated to be something like $4 to $18 for every one used on the system level. So there's really a clear value and a good return on investment in primary prevention. Now, in Iceland, the story was originally that we didn't really know where we were standing with regards to drug use. We always knew that our kids drank kind of badly, and we were very kind of limited on our own rule setting and monitoring, and, kids kind of roam around free. But, our alcohol culture in particular was quite bad. Kids would drink a lot. They would drink to get drunk. They would pass out. Downtown area of the main city would be filled with people drunk on Fridays and Saturdays. And it was pretty normal in society that kids would start to drink, 13, 14 years old. It wasn't really until we acquired comparative data that we were able to see that, well, actually, this is quite bad comparatively in this country compared to others. And the original SBAT studies, the European School Project on Alcohol and Other Drugs that you have probably heard of, they showed this definitively. They showed this very clearly, that kids in Iceland drank more than most others. We were in the top, I think, 5 or 6 of 35 plus European countries comparatively in the 1995 and 1999 SBAT studies. Along with that, not only are our kids drinking and smoking at a high level and using marijuana and cannabis and so on, they're also much more likely to get into trouble because of their drinking, such as into accidents, violent episodes, and various other problems. And this is the true part that's so important for primary prevention, is that the issue is not just the early use. The issue is that kids that start early, they're so much more likely to get into all kinds of other challenges, including, like I said earlier, dropping out of school, becoming parents very young, and getting into accidents as examples. So there's ample reasons for why we should focus on primary prevention. And so, to cut a long story short, the national government of Iceland first created a system or a program in 1997 that was titled Drug-Free Iceland 2002. And at the time, those findings from the SBAT studies had become publicly known. And at the same time, many local news outlets and media were reporting that kids in Iceland are actually not so good in terms of alcohol and other drug use, or they are in a lot of trouble. So there's this mutual sense that we have to do something about this. At the time, we had been using typical sort of short-term educational programs, which usually are geared towards teaching kids about the harm of drugs, that, you know, you shouldn't do that because that's bad for your health. But they didn't appear to be working very well. And in fact, in many places they don't, but we still tend to operate educational programs like it is, or sort of under the assumption that if people know that they should act differently, then they will. But, you know, that really isn't how behavior usually works. Most smokers, for example, know full well that smoking is bad for them, but they continue to smoke. And so that's the same for the kids. Now, at the time of we started this Drug-Free Iceland program, we set a focus, or the focus for the model was set to focus primarily on environmental indicators. And that is to move away from teaching individuals that, you know, they are at risk and moving more into, okay, the impetus, the most likely scenarios with regards to risk and protective factors are in their environment, where they live, what kind of norms they are subject to, what kind of expectations and values society places on them, and what kind of opportunities society places in front of them. So there's a key sense in the beginning, which is based on sociological and criminological theories of delinquency, that we should move or alter the environment, and as a result, we will be able to enable our kids to behave differently. So as opposed to stop saying, hey, you have to change your life, let's say I'm going to expose you to much more interesting environment, and as a result, you will have much less interest in risky behavior like drug use. At the time, there was also set a very strong sort of foundational set for collaboration, that researchers should work with people that work in local practice, in NGOs, in schools, in healthcare setting, in leisure time programming, and so on, and work collectively on prevention, not just as a separate program that is manualized and organized by a third party, but by a focus on key collaboration and input, both from researchers and practitioners and policymakers that make decisions about funding, that make decisions about gatekeeping, and are critical gatekeepers or openers towards prevention. They should be at the table. So working on this mutually, we come down to the community level, which means that we have to have members of the community with us in this work. Now, interestingly, research shows that people spend 90% of their time or more within about 10 kilometers of their home. That means that if we are going to be impactful in prevention, we need to gear our work towards the local areas because most people spend most of their time in their local environment. At the time of the Icelandic prevention model launch, which really was this Drug-Free Iceland 2002 program, which was temporary 5-year funded program by the government, key organizational levels were well arranged, and those were the national government that provided financial and administrative support, the municipalities that contracted with researchers and worked on funding and operating both leisure time programs, but also the school system, and obviously local school community agents such as parents, peers, and others. That's where most behavior takes place. So these levels were really organized well and explained when we started the work. To this date, those are really important when it comes to the actual implementation. And one of the final things that I think was so important in the work in Iceland is that they did not time this work to be a temporary. It wasn't organized to be a temporary thing. It was organized in the beginning to be an annual routine operation. So we operated with systematic annual survey data that was then disseminated to collaborative communities in municipalities and with community leaders every single year. And that's how the sort of ball got rolling. So there was a sense that we're going to do this as a matter of repeated and changed way of working. Now, we've documented this work in and published now in a paper titled "The Prevention is Possible: A Brief History of the Origins of and the Dissemination of the Icelandic Prevention Model." And this is in open access and should be available to you if you are interested. Now, okay, so what is the Icelandic prevention model compared to or given what most prevention systems are like? Well, the challenge is that in the current most common scenario in most places, including here in the US, prevention is usually operated with a cycle of short-term programs or short-term intervention strategies. So the idea is that you take a manualized program of some kind, you bring it into a community, you execute that program according to the manual with temporary funding. You provide an abundance of temporary resources just while you're doing this. And then we do comparative measurement before and after with maybe a comparison group while that program is being implemented. But when the program dries up, when the money dries up and the program is over, which usually is just a few months or maybe a year at most, we simply say, thank you very much, goodbye, see you later. So the current paradigm, the challenge with the contemporary paradigm of prevention is that it is kind of a cyclical system of execution of grants and programs. And I usually refer to this as the hamster wheel of grants and programs. Now, when communities execute this and when communities operate in this way, they become very desensitized to this notion that, no, we're not really making any long-term impact. We're just operating another grant-funded activity. So grants, programs, and obviously the kids and the people that live in different communities, they become very used to this fact that, yes, there is somebody here from the outside. They are doing a program here for a few months. They may bring in a little bit of resources at the time, maybe a couple of gift cards and a few meals. But when they're done with their program, they're done and gone with. Now, unfortunately, most evaluation exercises also are geared towards only measuring short-term impact. Because if I operate a 6-month program today, it's not going to impact the kids that weren't a part of the program next year or the following year or the year after. And the people that were subject to the program at the time of execution, usually the impact wears off pretty quickly. So in other words, if I execute a 3-month intervention program in your community, you most likely see something like a spike effect, and then that effect wears off in a few weeks or months. So in other words, if we're truly interested in making real change, real world change in the field of prevention, we should really think more about systems level changes at the community level and at the environmental level, as opposed to just short-term blip effects, which is really what most programs do today. So there's an abundance of programs out there that have been evaluated, but almost all of them have been evaluated for short-term impact. It's rare to see programs evaluated for long-term impact. They do exist, but they're very rare. But the issue is also that even though you have a long-term evaluation based on some kind of evaluation criteria, you're still not fulfilling this sort of population level impact for the long term for other cohorts too. So in other words, you're setting yourself up for repeated allocation or repeated execution of a program for every single year. The question, of course, is, but okay, instead of doing that, why shouldn't we just change the environment and have less drug problems? Wouldn't that make more sense? And that's exactly what the Icelandic model is about. So there's replication challenges with regards to the current primary prevention paradigm, because we have this system of odd programs coming and going. Sustainability and or long-term impact is usually very questionable and not evaluated. Most, as I said, most programs do not evaluate for the longer periods of time. And infrastructure and capacity building at the local level is usually not part of the way that programs tend to be evaluated today. So as a result, if we think about the community level and people that live in neighborhoods, or in rural communities, or in towns or villages, we see that, well, if we have a program that comes in here for a while and then is just out of the door in 6 months or a year or something, it really doesn't fit our reality with regards to a permanent change. And that's exactly the difficulty. That's the issue. That's the challenge, is that prevention is operated on a program sequence, this hamster wheel, rather than saying, listen, we have a problem in this community because drug use by youth, as I'm sure you know, and by adults for that matter, is not randomly distributed in the population. They're the same areas, the same pockets, the same towns, villages, neighborhoods, and postcodes that usually provide most of the new users. So there's concentrations of challenges located here and there throughout. And those are the ones that we should be working with. So in order to make a change at a community level, we really should think much more broadly about a wider level of impact. Now, we are not the only ones to think about this, by far, we, the proponents of the Icelandic model. There's multiple others that have thought about this. Tom Frieden, the former director of the CDC, for example, wrote an influential paper and published in the American Journal of Public Health in 2010 titled The Health Impact Pyramid. And the Health Impact Pyramid is really a way to show how you can reach a population impact while working with an increased or decreased individual level of need. So, for example, if you go towards the upper part of the pyramid, you're going to work much more on the individual level. So at the top of the pyramid is counseling and education. That means if you're going to work at the counseling education level, you're basically working on a one-to-one level. That has very limited population impact. That impacts only the people that are subject to that. Now, at the bottom of the pyramid, on the other hand, if we can move everybody out of poverty, at the bottom of the pyramid is socioeconomic status or indicators. For example, if we could move everybody out of poverty, we would have much more impact than we are proportionally working with individuals. The Icelandic model really focuses on the fourth tier in the triangle, which is, or the pyramid, which is the changing the context to make individuals default decisions, the healthy decisions. This is the idea that kids are grown out of their environment. This is the theoretical focus of the model, coming from sociology and criminology. You create good environments, you will produce healthy people. We create environments that have lots of challenges, that have very little opportunities, little love and support. We're definitely going to have more challenging individuals coming out of that. It doesn't seem like very complicated an issue. So towards the bottom of the pyramid is a greater level of population focus and population impact. While at the same time, less individual effort needed. We can operate things at a population level without reaching every single individual. You change the system, and as a result, individuals will behave or choose to behave differently. Now, there was a recent review that appeared in 2024 in this journal, Systematic Reviews, about community mobilization approaches to prevent adolescent multiple risk behaviors. The Icelandic prevention model is prominently discussed in this review as an example, and it does focus much more on the community level of work as opposed to the individual level, particularly educational programs. So there's one excerpt there from the paper saying there's an increased recognition that community mobilization approaches could be beneficial for adolescent health. For community mobilization interventions to reduce adolescent multiple risk behaviors, the coalitions within them must seek to alter the social environment in which these behaviors can occur. Now, this is important here because they are assuming that coalitions within communities, community coalitions, are the way to go with regards to prevention. And the Icelandic model focuses very heavily on collaboration. Coalitions are the collaborative unit at the community level. A group of senior people in public health and health promotion also published something in 2011 titled Applied Social and Behavioral Sciences to Address Complex Health Problems. And they're basically saying very similar things. They're basically saying that we need a fundamental shift in research and evaluation of health promotion and prevention that doesn't necessarily operate at universally applicable interventions, but focuses on each individual community specifically. And they argue for what they call the toolkit approach. So they're sort of referring to this and likening it with what happens in engineering, for example. If you're an engineer, you build bridges, you just don't have one design of a bridge and you always build the same bridge. You tend to probably go to different environments and then design the bridge in accordance with the environment that you work in each time. That's exactly what the Icelandic prevention model is about. You look at the environment first, you take your measurement, you do your assessment and evaluation, and you figure out, okay, this is that kind of environment. We need to focus on and work accordingly. This is getting much, much more prevalent as a viewpoint today. There was a new article or a recent article by Sili Sloboda and colleagues that appeared in Prevention Science in 23 titled The Normalization of Prevention Principles and Practices to Reduce Substance Use Disorders. And they ask for or call for what they call an integrated dissemination and implementation framework, which the Icelandic prevention model is. It's an integrated framework that focuses on dissemination and collaboration. So here too are a group of senior scientists in this field that are calling for the normalization of prevention principles as opposed to single individual programs. And even people from the communities that care system, they have now started calling for and asking for community coalitions to prevent challenges in communities. So there is lots of appetite out there for this idea that collaborative systems with and through community coalitions that in the original Icelandic work in Iceland were built within and between municipalities and researchers. So the municipal level was really the community level in Iceland. So this is sort of the background of the model. Let me now give you a couple of examples of implementations, both in Iceland, but also in West Virginia, where I live, and I have been testing and working on the model since. Now, the model in its simplest terms is described like this. Our viewpoint is that each individual, each kid, each youth and family we work with is a subject to 4 major domains of risk and protective factors. And those are parents and family, the peer group, the school environment, and leisure time. And our risk and protective factors that we assess in the surveys that are a part of the Icelandic model come from within those 4 major domains. We then assume implementation at a local school community and the municipal or county level. That seems to be the local areas that make most sense in terms of operationalization. We've described the model in numerous publications, but the first one appeared in 2009 in the journal Health Promotion International. So when you see the survey work conducted under the Icelandic prevention model, they come from the measures in there and risk and protective factors. They come from these four major domains, and they're all geared towards or come from major research in this field. We tested these assumptions with longitudinal data from Iceland a few years ago. And what we were aiming at focusing on there was the assumption that there are multiple risk and protective factors at play at any given time. It's not just one or two, as many intervention programs tend to focus on. It's really risk and protective factors within all those four domains. And we found in this paper that there are indeed risk and protective factors from all of the four domains: parents and family, the peer group, the school environment, and their leisure time or the third space or free time, that all are active at the same time. So if we are thinking about prevention as a single variable issue, which unfortunately tends to be quite common with funders, for example, that it isn't really that simple. We should focus on environmental buildup as a whole. Now, we have repeated this test in a paper that is now in re-review and probably should be accepted pretty soon. This is from data from West Virginia. We basically replicated this study from Iceland. We did the same thing with data from the US, from here in West Virginia, where I live. And we found exactly the same thing. Multiple risk and protective factors are at play at any given time. It's not just the parents or just the homes or just the school or just the community or lack of opportunities for leisure time programs or sports. It's all of the above. So, if we are thinking about really truly building community capacity for prevention, we need to think about the environment as a whole. Now, you've seen this figure, I'm sure, many times. It's really about how this work was executed in Iceland in the beginning. We began during the late 90s when those ASPAT studies were coming out to show that the Icelandic kids, Icelandic youth were in heavy challenges with their use. At the time, this is in 1998, 42% of 10th grade students admitted to having been drunk in the last 30 days. 23% were daily tobacco users or daily smokers, and 17% had used cannabis substances. It took about 15 years till about 2012 or thereabout to drive these numbers down to about 6% for drunkenness and smoking, drunkenness and cannabis use, and about 1% for daily smoking. Now, obviously, we have our challenges with e-cigarettes and those other things too, but not nearly as heavily as in many other places. I think there's really two major stories being told by this graph. It's the period of the downturn. It's the reduction in use, which took about 14, 15 years, which is way longer than most short-term programs are willing to, and most funders are willing to pay for. It really shows the value of longevity and continuity and sustainability in the changing the nature of our work. And the other half of it is really the sustainability piece, that we have changed this for good. Kids now in Iceland, think about 10th grade students today versus 10th grade students in the 90s, they're exposed to completely different environments. Kids are cared for differently. The norms in society are different. We do not expect them. We do not accept them being drunk late at night in the weekends. We provide them with a much better network of opportunities. And as a result, they have very little reason to go out and just take risks and do the stuff that we did when I was 15, for example, which was in 1990. Now, another thing that has changed, interestingly, in Iceland during the same time is that treatment enrollment for young people has plummeted. It's been reduced a great deal, even though the Icelandic prevention model isn't about drugs at all, and certainly not treatment. We have shown that by reducing or focusing strongly on the population of young people that are starting early to delaying that onset as long as we can, there are simply much less need for drug treatment for kids later on. So this figure shows from the SAA annual report from 2016, which is the largest treatment center on the outskirts of Reykjavik, that in 2002, though this is the 1982 cohort, young men at the age of 20 and younger, 5.7% of them came to drug treatment. That number is only 2.6% for the 1995 cohort. Those are kids or young men, that are 20 years old or younger in 2015. So while this was happening, and you look at this sort of left-hand side of the graph, while that was happening in the population, this was happening in drug treatment. So during the time when we were primarily focused on drug treatment, on population prevention here, this is what happened in drug treatment. So we have more than halved our need for drug treatment while focusing primarily on primary prevention in society. So there's clearly a very strong relationship between those two entities. We created and conducted a quasi-experimental study into the work in Iceland. This was actually the last of 4 papers in my doctoral dissertation at the time. And we found very similar results, that communities that had been using the Icelandic model effectively and those that had not been using it, they were significantly different from each other, both with regards to risk and protective factor development, but also substance use outcomes. So even in small Iceland, communities that operated the model well, they were very differently trending than communities that did not simply use the model at all. So the question is, okay, so what did Iceland really do? Well, Iceland built a collaborative and process-based infrastructure. It did not operate a single program. Programs are certainly still operated in Iceland as a part of the model, but they are operated as a targeted different kinds of interventions where the need is the greatest, because the model focuses on and gives us an indication of how to prioritize needs and focus on the best potential solutions through this dissemination and integration pipeline. So routine annual data collection is conducted to guide prevention practice. That's part of the model. It's a theoretically grounded survey. It's not just about this and that and the other thing. It's about things that actually make sense from a theoretical point of view about improving the environment of kids. We work with manageable number of risk and protective factors within the 4 domains of parents and family, peer group, the school environment, and leisure time. In other words, we do focus on a set of risk and protective factors every time, but we choose and usually work with our collaborators at the community level on 2 or 3 important ones. Good thing about risk and protective factors is that they are strongly interrelated. So when we work on a few strong big ones, we have a tendency to see lots of positive changes. We produce practice-based data reports within 2 to 3 months of data collection every year, which means that when we have new data, both recent and localized in our hands, we're much more likely to be able to both get other people on board with us, the communities as a whole, and to focus our efforts and resources at the right location. Iceland hired primary prevention specialists in every municipality, in every community, which means that there's somebody at the table that actually carries the ball and carries the load within each community. This is really important. We call those county coordinators where I live here, but the same principles apply. The data and this pipeline, this system, facilitates a collaborative partnerships between researchers, policymakers, and practitioners. We're all in the same boat. It's not an external mandate or an external program where I just show up and tell everybody what to do. It's really a call for much stronger collaboration. There is abundance of structural changes and interventions that were done in Iceland, but they all stem from the origins of the model. So Iceland created this leisure card voucher system where people can use to pay for organized activities for their kids. They set rules around outside hours so that parents would have something mutual to work with. No, these are not curfews. Nobody's being arrested for being outside. That's not the case, and as has been highlighted in some news media, it's really just a way of setting some common rules for our kids. So in summary, and I apologize for going over the 45 minutes, in summary, what is the Icelandic model about? Well, it's about primary prevention. It's not so much about drugs. It's more about community building and collaboration. We focus on environmental change, not on individuals or individual responsibility for their behavior. It's very community and collaborative and practice oriented, and it allows for variation between local areas. It's not a top-down program, but an infrastructure. It's a collaborative between researchers, policymakers, practitioners, and community members. And it's consistent and repetitive. It doesn't really have a defined time limit. Reporting, importantly, at the data reporting level is within the practical utility. It's at the local level where most people actually live and work. Thank you very much. Hope you have a great conference.